Very good morning. Very good morning. Welcome to the platform of eGurukul. So today we are going to do about the obstetrics session. So in obstetrics, the first topic I'm going to start is with the basics of reproduction. So these first 3 days we'll be doing the obstetrics, and then the last 2 days we'll be doing the gynecology, and everything will be notes based. I want you to take notes, and if you're perfect with these notes, I can assure you that 100% you can answer. And obstetrics and gynecology is a very important subject for you, because it's a highly scoring subject. Almost 25 to 30 questions you get. 30 में से 25 आराम से you can crack. So 25 marks will be in your pocket, right? So that's the advantage of becoming perfect with obstetrics. So any point of time, if you don't understand anything, feel free to ask. We are gonna enjoy this session. We're gonna have a lively class with. We will understand everything. Obstetrics is also conceptual, so you will understand the concepts, and once you understand the concepts, whatever question they throw against you, you'll be able to answer. So that's the beauty of this session. Okay, so let's start with the session. Very good morning. Very good morning. So the first question which I always ask the students whenever we start the session is, who are very complicated, girls or boys? So yesterday was a Valentine Day, no? How did you enjoy the Valentine Day? Did you all meet up the expectations of your girlfriends or boyfriends? Hi, hello. So what do you think post Valentine? Who is very complicated, boys or girls? Yes, myself, I'm Dr. Ramyasree. I teach obstetrics and gynecology. Oh, yesterday you had biochemistry class instead of Valentine. Oh, no problem. I think after 6 months, once you finish your exam, you can aram se celebrate Valentine. No? Fine. So I see many of you answering that girls are very complicated compared to boys. I too agree with you. Girls are little on a complicated side compared to boys. Same is with the spermatogenesis and oogenesis. Spermatogenesis is simple. Oogenesis is little complicated. Matlab, it will be stop, atak ke, it will finish. Now, whether it is spermatogenesis or oogenesis, there are only 3 steps. That is mitosis, meiosis 1, and meiosis 2. So we mainly have only 3 steps. That is mitosis, meiosis 1, and meiosis 2. So first, I'm going to start with the spermatogenesis. My next question to you is, who always have lot of forward thinking? Matlab, abhi se hi you have a plan like what will be your bachcha's name, and what will be where they'll study. So much forward full thinking will be for boys or girls? Right. Very good. The forward thinking or excess thinking is also with the girls' genes. So boys are abhi ka abhi, whatever happens, fine. Now this is all just for fun. So why I am telling that is, spermatogenesis should start when? It should start at puberty. So spermatogenesis starts at puberty itself. But oogenesis starts way back in utero itself. So spermatogenesis starts at puberty. So we have the spermatogonium. So spermatogonium is 46XY. Spermatogonium will undergo mitosis. to form primary spermatocyte. This is very simple, but yet you have to know it perfect. Okay. Spermatogonium undergoes mitosis to form the primary spermatocyte. Primary spermatocyte undergoes meiosis 1 to form secondary spermatocyte. This further undergoes meiosis 2 to form spermatids. Spermatids will transform further into sperms. Now, my question to you is, which among the following is a reduction division? Which among the following is the reduction division? So, where does the number of chromosomes become half? So, I wrote spermatogonium is 46XY. What will be the karyotype for primary spermatocyte? Excellent, Dharmesh. So the reduction division is primary spermatocyte to secondary spermatocyte. The reduction division is primary spermatocyte to secondary spermatocyte. So primary spermatocyte is also 46XY, but when it becomes the secondary spermatocyte, it becomes half. So it becomes 23X or 23Y. So spermatogonium will form primary spermatocyte, which will become secondary spermatocyte, which will further become spermatids. Now we all know that sperms are not round cells. So this spermatid will further transform into sperms. And the spermatid transforming into sperms is called as spermiogenesis. Is called as spermiogenesis. Spermatid transform into sperms is called as spermiogenesis. Okay. So very simple. You have only 3 steps: mitosis, meiosis 1 and meiosis 2. Now what transforms into what in the spermiogenesis also, let's see. So I hope you have all jotted down the spermatogenesis. So in spermiogenesis, the round cell or the spermatid will transform into sperm, guys. So what happens is the Golgi apparatus of the spermatid will transform into acrosome of the sperm. So Golgi apparatus will transform into acrosome of the sperm. Whereas the nucleus will transform into head of the sperm. The mitochondria will transform into middle piece. Mitochondria will transform into middle piece. Whereas the centrioles will transform into tail of the sperm. So these are of the spermatid and this side is of the sperms. Okay. So where does the maturation of spermatid take place? Maturation of spermatid or the formation of spermatids takes place in seminiferous tubules. Whereas maturation of the sperm or the motility of the sperm is obtained in epididymis. So maturation of the sperm or motility of the sperm is attained in epididymis. So the formation of spermatids is in the seminiferous tubules. Actually, spermatid also undergoes 5 steps to transform into the sperm. So the first 4 steps are in the seminiferous tubules itself. But the last step is in the epididymis. So motility of the sperm is also attained in the epididymis. Okay. Now some more points which you should know about the spermatogenesis is, so the process of spermatogenesis takes place around 70. So spermatogenesis starts at puberty. Lifespan of the sperm. Who will wait for a longer time on Valentine's? Girls wait or boys wait? I know you'll all start telling me that you didn't celebrate Valentine's Day. Okay, no problem. You can celebrate after your exam. So who waits for a longer time, girlfriend or a boyfriend? So same way, who will wait for a longer time, the ovum or the sperm in the fallopian tube? Very good, excellent, good. Boys wait for a longer time. Even sperms also wait for a longer time. Sperm will be waiting for 72 hours for the ovum, but ovum will come only for 24 hours. If that time, if sperm is present, fertilization takes place. Otherwise, no fertilization. So lifespan of the sperm is longer than ovum. That is why I'm trying to tell you this. So boys wait for a longer time. Same with the sperm. Lifespan of the sperm is 72 hours. Okay. Size of the sperm, it's very small, 55 microns. So spermatogenesis starts at puberty. Lifespan of the sperm is 72 hours. Size of the sperm is 55 microns. Time taken for spermatogenesis. Everything is almost like 72. So time taken for spermatogenesis is 72 to 74 days. So time taken for spermiogenesis is 14 days. One spermatogonium will give rise to 16 primary spermatocytes. One spermatogonium will give rise to 16 primary spermatocytes. And each primary spermatocyte will give rise to 4 sperms. So one spermatogonium is giving rise to how many sperms? So one spermatogonium is giving rise to how many sperms? So one spermatogonium will give rise to 16 primary spermatocytes. Each primary spermatocyte is giving rise to 4 sperms. So one spermatogonium is giving rise to how many sperms? Excellent. Very good, Arjun and Dharmesh. It is giving rise to 64 sperms. So these are some of the important points which you should know about the spermatogenesis. Now we'll go to the oogenesis. So many times, now I want you to give full attention here. Very good, Devi. So many students always get confused between what is folliculogenesis and what is oogenesis. Remember guys, folliculogenesis is different. Folliculogenesis is development of primordial follicle to dominant follicle. So that is a different story. Oogenesis is a different story. Another point, remember, follicle is like a balloon. Balloon ka transformation folliculogenesis. Oocyte is like a marble inside the balloon. Oocyte is like a marble inside the balloon. The changes which are happening in that marble is the oogenesis. So both are separate but both live together. So both I will be discussing at a different point of time. Folliculogenesis we learn when we are doing with the menstrual cycle. Right now I am discussing only what is happening in the marble. Oogenesis mein kya ho raha hai. Okay. So I told you girls have a lot of forward thinking. So same way the oogenesis starts way back in utero. So oogenesis starts in the intrauterine life. So it starts around 9 weeks of intrauterine life. But do you want the woman to have ability to sexually reproduce from 9 weeks of intrauterine life? Do you want the oogenesis to start from 9 weeks of intrauterine life itself? Obviously no, right? So this primary oocyte lies inside the follicle I told you. So primary oocyte is present inside the follicles. So which is nothing but the granulosa cells. The follicles contain the granulosa cells. Okay. So these granulosa cells are like motherly. They'll be like, beta, let's not start reproduction so early. So what they do is, so first oogonium undergoes mitosis to form primary oocyte. Oogonium undergoes mitosis to form the primary oocyte. So it starts, but the granulosa cells is like a motherly, it will feel like, no, we should not start the reproduction so early. So what this granulosa cells do is, they secrete something called as meiosis inhibiting factor. They secrete meiosis inhibiting factor. Okay. So this meiosis inhibiting factor arrests the primary oocyte in what is the first phase of meiosis? What are the 4 phases of meiosis, guys? What are the 4 phases of meiosis? Prophase, metaphase, anaphase, telophase. Right? So it arrests the primary oocyte in prophase of meiosis 1. So it arrests the primary oocyte in prophase of meiosis 1. Okay. If I have to be more precise, but nobody asks you so much. So I don't want you to use your, see there are 19 subjects. One important point I'll tell you guys. Your notes should be in such a way that when you're revising, it should be a cakewalk. ऐसा नहीं है कि जो भी मतलब whatever is there, everything you'll jot down in your notes. And when you come back for revision, you'll be like, oh my God, what is this? No. My purpose of teaching is, I'll give you a crisp notes which is most important and which will come in your exams. I'm not going to enload you with multiple things which are not necessary. Okay. So that is another important point. Your notes should be crisp enough so that when you're revising, it should be a cakewalk. And when you're reproducing back it in your exam, it should be like, matlab, awesome. Right? So here, if I have to be precise, it is actually, it gets arrested in diplotin phase of prophase of meiosis 1. But again, as I told you, you don't require, nobody asks you all such questions nowadays. There are more questions on the clinical based Okay, so we'll concentrate there more. Yes, so primary oocyte is arrested in diplotin stage of prophase of meiosis 1. Right. Very good, Arjun. So, Momin, when do you want the when do you want the woman to start her reproduction? The ability to reproduce. So, you want her to start to reproduce from at puberty, right? So, what does the primary oocyte do is, so at puberty, with the help of LH, luteinizing hormone, there will be resumption of meiosis 1. So what happened? This primary oocyte will complete all phases, and meiosis 1 is a reduction division. Number of chromosomes will become half. So the primary oocyte will divide it into, it will release first polar body. So at puberty, there will be resumption of meiosis 1 with the help of LH. And it will release first polar body. So first polar body will be a more of nucleus and very little cytoplasm, and it will be a small cell. So first polar body is released when we have LH surge peak released at LH surge peak, that is 10 to 12 hours prior to ovulation. And then it will release the secondary oocyte. So secondary oocyte is released at ovulation. What will be the chromosome number for primary oocyte? What will be the chromosome number? What will be the chromosome number of primary oocyte? So primary oocyte will be 46XX. First polar body will be 23X and secondary oocyte also will be 23X. So at ovulation, at puberty, the secondary oocyte is released. Now this secondary oocyte is waiting for a good dulha. So first it has waited all long for puberty, and now the secondary oocyte is waiting for the dulha. So once it is waiting for the sperm. Only if sperm comes, it will finish the meiosis 2. Otherwise, secondary oocyte will undergo atresia along with the follicle. Okay. So at fertilization, so this secondary oocyte is arrested in, what is the second phase? Secondary oocyte will be arrested in second phase. What is the second phase? It is a metaphase. So secondary oocyte is arrested in metaphase of meiosis 2. It's arrested in metaphase of meiosis 2. So this secondary oocyte will complete the meiosis 2 only if there is fertilization. So at fertilization, it will release female pronuclei. It will complete the meiosis 2 and it will release female pronuclei. And after fertilization, it will release second polar body. So this is regarding the oogenesis. Now, as of now, you will feel okay. But later, when there is any MCQs, you might have a little problem in answering. So I'll tell you an easy way of remembering. So for primary oocyte, everything is in first phase. Everything is 111. First phase, first meiosis, First polar body, everything 1. Secondary oocyte, everything is 2, 2, 2. So secondary oocyte is arrested in which phase? Second phase, that is meta phase. It is arrested in which meiosis? Meiosis 2. And it is releasing which polar body? It is releasing second polar body. Okay. So for secondary oocyte, everything is the 2, 2, 2. Right? So that is regarding the oogenesis. Now I'll quickly revise the oogenesis once we write some more points. Now I would like to ask you one question, guys. So you understood the oogenesis, right? So oogenesis mein what is happening? We'll quickly have a recap. So we first had oogonium undergoing mitosis, forming the primary oocyte. So this primary oocyte was arrested in first phase, that is prophase of meiosis 1, right? So it completes this at puberty with the help of LH. So at puberty, it releases secondary oocyte and first polar body. First polar body is released 10 to 12 hours prior to ovulation, whereas secondary oocyte is released at ovulation. Secondary oocyte is arrested in metaphase of meiosis 2. At fertilization, it releases female prenuclear. After fertilization, it will release second polar body. So they both will be present in the perivitaline space. Okay? Now, if you do a cut section of the ovary, what are the cells which you will see at birth? If you have done cut section of ovary at birth, what cells which you see? What cells do you find? Option A, you will find oogonium. Option B, you will find primary oocyte. Option C, you will find secondary oocyte. Option D, you will find first polar body. Sparkle Shine, this is a session happening, 5-day session for very good, Sachin, excellent. So I'm waiting for the answer. Very good, Raima and Seljin, correct. So cut section of the ovary at birth, you will see which cells? It will be the primary oocytes. Because in utero, all the oogonium has transformed into primary oocyte by the help of mitosis, right? So in utero, at 5 months of intrauterine life or 20 weeks of gestation, you will see the maximum number of primary oocytes. So we have around 5 to 6 million primary oocytes. Among these 5 to 6 million primary oocytes at birth, we'll have only 1 to 2 million primary oocytes. So rest, only 1/5 will remain, rest all will undergo atresia. Among this 1 to 2 million, at puberty, you'll have only 4 to 5 lakhs left. In this 4 to 5 lakhs, there are only 400 oocytes which have the ability to mature. Only 400 oocytes mature throughout the woman life. Rest all are again atretic. Rest all will undergo atresia, right? At menopause also we are still left with 1000 oocytes, but they don't have the ability to undergo maturation. So what do we call when all these 400 oocytes finish? What do we call that as? So what will we call when this 400 oocytes completely they are over in the woman? What do you call that state as? That is called as menopause. So do you understand why does a woman has menopause? So once these 400 oocytes are depleted, then they don't have, they'll, that's menstrual cycle, nothing will be there. So that state we call it as a menopause. So somebody it can finish early, somebody it can take late, more time. So depending on that, we have different ages for menopause. Okay. So these are the important points for the oogenesis. Now we'll see some MCQs, guys, post. So in the spermatogenesis and oogenesis, we'll see some MCQs. So I want you to do the sequential arrangement of the following. So do the sequential arrangement of the following. So what comes after what is my question. So the first thing which will come is oogonium. So E. After the oogonium, we have the primary oocyte. So A. After primary oocyte, what is the next thing which is going to come? So it is EAC. Excellent. So after that, you have the first polar body and then you have the secondary oocyte. So EAC, B, and last after the secondary oocyte, then we have the second polar body. So D. EACBD. Excellent, guys. Very good. So here more, see, you don't get this type of questions in your exam, but I want you to just, this will bring out more better from you. So that is why I have framed these questions. Okay. So these are, this format is not, this is not the format which you will get in your exam, right? You will get single best answers, but try to answer these. Primary oocyte, you have to answer which all options are correct here. Is formed after single meiotic division, is maximum in number in 5th month old fetus, is in prophase arrest, also called as blastocyst. So primary oocyte is formed after single meiotic division. Is this true or false? I want you people to answer this point. Is maximum in number in 5th month old fetus? Think again, is A correct? Primary oocyte was formed after single meiotic division. Very good, Shweta and Das Gupta. B and C are the correct answer, right? So A is wrong. If you remember, I told you oogonium will form after mitosis primary oocyte. So primary oocyte is formed after mitotic division, not single meiotic division. So A is false. It is maximum in number in 5th month old fetus is true, 6 million. It is in prophase arrest is also true. So B and C are correct. B and C are correct. It is not called blastocyst. It is not called blastocyst, right? One last question. Yes. Again, in this, you have to choose which are the options correct and tell to me. Okay. Right, A is false. Okay, now next. So in this question also there are more than one options which are true. So tell me which all options are true and then I'll speak about it. So primary oocyte arrests in prophase of first meiotic division. Primary oocyte arrests in prophase of second meiotic division. So first statement, primary oocyte arrests in prophase of first meiotic. See, when you read like this options, no, you'll feel what is this in the exam. So that is why I told you ki remember primary oocyte ka everything in first phase, secondary oocyte ka everything in second phase. So primary oocyte arrests in prophase of first meiotic division is right. I have the answer here. You have given me A, D, E. Very good, excellent. So primary oocyte arrests in prophase of first meiotic division is true. Primary oocyte arrests in prophase of second meiotic division. No, primary oocyte का सब कुछ primary, prophase first. So this is wrong. Next you told me that C, secondary oocyte arrests in metaphase of, it should be second meiotic division. So this is false. Secondary oocyte arrests in metaphase of second meiotic division. True. Second ka everything second. First polar body is extruded during first meiotic division of primary oocytes is also true. So A, D, E is correct statement. Excellent. Very good. Right? So I hope all of you understood the spermatogenesis and oogenesis. So now Dulha and Dulhan both are ready. Dulha and Dulhan both are ready. Next is the fertilization, right? So we have the male gamete and the female gamete. The next step is the fertilization. So fertilization takes place in what is the site of fertilization, guys? So it takes place in ampulla of the fallopian tube. So fertilization takes place in the ampulla of the fallopian tube. So if you precisely tell it is isthmo-ampullary junction, but when I tell isthmo-ampullary junction, when you have in options ampulla and isthmus, you will be confused. So remember, it takes place in the ampulla of the fallopian tube. Okay. So so once the fertilization takes place, you have the zygote formed. So zygote will be two-celled. So this zygote will further divide into to undergo full mitosis. So from 2-celled it will become 4-celled. From 4-celled it will become 8-celled. From 8-celled it will become 16-celled. This 16-cell is called as morula. So this 16-cell mulberry-like is called as morula. So according to Williams, day 3 morula is formed. Day 3 morula is formed. Okay. So this morula enters the uterine cavity on day 4. So day 4 it enters the morula enters the uterine cavity. Day 5 fluid seeps into this morula. So day 5 it becomes blastocyst. Fluid seeps into this morula and it becomes, all the cells will come to one side, which we call it as inner cell mass, and there will be a fluid filled cavity that is called as the antrum. So this is called inner cell mass and this is called as the antrum. And there will be outer layer also that is called trophoblast. So this inner cell mass will become in future the embryo, whereas the trophoblast will become the placenta and it will form the fetal membranes. So in the fetal membranes, we have the outer chorion. Outer chorion will form the placenta in future, and inner amnion. So inner amnion will be the covering the baby, where you have that amniotic sac. So day 5, blastocyst is formed. Now one more point which I have to tell you here is, why does only single sperm fertilizes the ovum? Why not more than one sperm? Why not more than one sperm? So once the sperm enters, once one single sperm enters, the nucleus of the sperm enters into the ovum, into the oocyte. What happens? There will be thickening or hardening of the zona pellucida. So zona hardening prevents the other polyspermy. But when you have zona hardened, it cannot get implanted. So on day 5, there is one more thing which is happening, that is zona hatching. That is dissolution of zona pellucida. Day 6, this gets implanted. So day 6, implantation begins. Now again, all these days which I am telling is after ovulation. So after fertilization, these are all the days. They are not from the last menstrual period. So when I am telling day 3, it is day 3 after fertilization. Day 4 after fertilization. They are not from the day last menstrual period. Okay. So day 6, implantation begins. Day 8, the trophoblast which is there, no, it will differentiate into inner and outer. So the day 8 trophoblast differentiates into inner cytotrophoblast and outer syncytial trophoblast. Next, day 10, implantation completes. Day 10, implantation completes. At the time of your implantation getting over, there can be some bleeding, minimal bleeding coming out per vaginal, and that is called as implantation bleeding. It is physiological, self-limiting, stops by itself, not to worry. Okay. So day 10, you can also see some bleeding per vaginal, that is called as implantation bleeding. So all these are the day-wise events which you have to remember, guys. So you can have minimal bleeding per vaginum, that is called as implantation bleeding. So day 10 implantation completes and there will be minimal bleeding per vagina, and that's called implantation bleeding. So these are the day-wise events which we have. These are the day-wise events which we have. So what were day 3? Morula is formed. Day 4, morula enters the uterine cavity. Day 5, blastocyst is formed. Day 5, zona hatching takes place. Day 6, implantation begins. Day 8, trophoblast will differentiate into outer syncytio and inner cytotrophoblast. And day 10, implantation will end, where you can see minimal bleeding, which is called as implantation bleeding. Okay. So these are all the day-wise events. And one more point which you should know is actually the sperm undergoes some more transformation to fertilize the ovum. So that transformation of the sperm to fertilize the ovum, or the ability of the sperm to undergo fertilization, is called as capacitation. So the sperm, the acrosome is there, no? That will release hyaluronidase in order to go inside the oogonium. So capacitation is ability of the sperm to undergo fertilization. So capacitation begins in the uterus. So begins in female genital tract. Maximum occurs in fallopian tube. The time taken for capacitation is 5 to 8 hours. So after the capacitation, then acrosomal reaction and then fertilization. Okay. So acrosomal reaction is acrosomal reaction is where the acrosome of the sperm will release, I know I'm little bad on the diagrams. So acrosome of the sperm will release hyaluronidase. So this hyaluronidase will cause dissolution of the zona pellucida for the sperm entry. Okay. So first is fertilization, followed by capacitation, followed by acrosomal reaction, followed by uh, first gamete formation, then we have the capacitation, then we'll have the acrosomal reaction, and then the fertilization. So after fertilization, I spoke about implantation also. So now I have few more points regarding the implantation. So implantation is where does the blastocyst gets implanted? In which layer of the uterus does the blastocyst gets implanted? So in which layer of the uterus does the blastocyst get implanted? How many layers are there in the uterus? Yes, Arif, Arjun, Dharmesh, Raima. How many layers are there? So we have 3 layers: endometrium, myometrium, and serosa. Endometrium will become soft, cushiony like. That is called as decidua in the pregnancy. So it is a progesterone which makes the endometrium into decidua during the pregnancy, right? So implantation takes place in the decidua. Implantation takes place in the decidua, right? So the blastocyst will come and sit in the decidua. Most common site of implantation is posterior wall, upper two-third body of the uterus. Most common site of implantation is posterior wall, upper two-third body of the uterus. Okay. Now after implantation, the decidua, please understand this point. Decidua is anatomically divided into three areas, not layers wise. The decidua is anatomically divided into three layers. Now, what are those anatomical division of the decidua? So, the decidua which is present below the blastocyst is called as decidua basalis. Don't get confused. It's very simple. Decidua which is present below. It is present below. So that is why you are calling it as decidua basalis. The decidua which is covering the blastocyst. As it is covering the blastocyst, so you are going to call it as decidua capsularis. The decidua which is covering the entire uterine cavity is called as decidua parietalis. So I hope you all understood this anatomical classification. So the decidua which is present below is called as basalis. The decidua which is covering the blastocyst is called as capsularis. The decidua which is covering the entire uterine cavity is called as decidua parietalis. Now tell me one thing, will baby be always so small or baby will grow? Obviously baby will grow, right? So when the blastocyst grows and fills the entire uterine cavity, then decidua capsularis and parietalis will fuse with each other, and that is called as decidua vera. That is called as decidua vera. I'll show you one more picture of all this also. So just write down this point. The next picture I'll show you with clarity in another. So at 14 to 16 weeks, decidua vera Decidua capsularis and Decidua parietalis fuse together to form Decidua vera. So at around 14 to 16 weeks, Decidua capsularis and Decidua parietalis fuse together to form the Decidua vera. So Decidua vera is formed at around 16 weeks. Decidua vera is formed at around 16 weeks. So up to 16 weeks, endometrium is open. Can you see endometrial cavity is open? So there can be some amount of bleeding coming out from this endometrial cavity coinciding with her last menstrual period, and that is called as placental sign or Hartmann's sign. So many students get confused between implantation bleeding and this. So I'll again repeat it. So placental sign or Hartmann's sign is bleeding up to 16 weeks, minimal bleeding per vaginum is minimal bleeding per vaginum coinciding with last menstrual period. So placental sign or Hartmann's sign is minimal bleeding per vaginum coinciding with last menstrual period up to 16 weeks. So what I'm trying to tell here is, Manu, her period's date is 14th Feb. So up to first 3 months, she can see some bleeding on her period date. Like 14th Feb, she is pregnant. That is her last menstrual period. 14th March, you can see little bleeding. 14th April, you are seeing little bleeding. So that is nothing but the placental sign or Hartmann sign. Now why are we seeing this? Again, this is self-limiting. You don't require to worry. It will be minimal bleeding per vaginum. Okay. So why we are seeing? Because endometrial cavity is not completely closed. Now we'll see the picture of all what I spoke till now. Zygote reaches the uterine cavity as so zygote will reach the uterine cavity as 16 cell. 16 cell, right? Very good. So if you observe this picture, so this is the embryo. So below the embryo, this layer is called as deciduum basalis. Is the picture visible to all of you? Is it clear? Or do you want me to zoom it? Shall I zoom it or is it visible to you? Okay. Right. So the part of the decidua which is present below the blastocyst or below the embryo is the decidua basalis. So can you see this decidua which is covering? This decidua which is covering is decidua capsularis. And this decidua which is covering the entire uterine cavity is the decidua parietalis. Okay. So decidua basalis, decidua capsularis, decidua parietalis. The MCQ which they have asked you was, so actually when you do a USG, I will show you all the USG pictures also guys. So when you do a USG, so in USG it will look like around the gestational sac 2 rings, and that is called as double decidual sign. There was one previous year MCQ which you people got. They asked double decidual sign is due to which layers? So double decidual sign is due to capsularis and parietalis. So this capsularis and parietalis covering will look like two rings around the gestational sac. So double decidual sign is due to capsularis and parietalis. Okay. Next. Now I told you the trophoblast also differentiates into membranes. So the inner membrane, this one which you're seeing, no, this one, this bluish, this is the amnion. This inner membrane which is covering around the fetus is the amnion. Outer to that green color one is the chorion. Outer to that green color one is the chorion. So the green color one so one part of the chorion is throwing finger-like projections. So the finger-like projections chorion is called as chorion frondosum. And the chorion which is not taking part in the formation of placenta, this chorion is called as chorion levae. So the chorion which is forming finger-like projections is the chorion frondosum. The chorion which is not taking part in the formation of placenta, it is not taking part, leaf, so chorion levae. Okay. Give me a thumbs up if you all understood all the layers. So did you all understand all the layers till here? Okay. Now we'll see the next part here. So now we'll see Decidia vera. So I want you people to now answer, and then we will discuss what is Decidia vera. So in the first picture, what is this? What is number 3 in the first picture? No, I'm not asking purple. Pink color. Pink color. What is the pink color? So the pink color one is the Decidia basalis. Easy, simple. It is present below, so basalis. If it is covering, you should tell capsularis. Okay. So the pink one, which is present below the blastocyst, present below, so basalis. Now what is this pink one, which is covering the blastocyst? Number 2. So number 2 will be Decidia. Yes, number 2 will be Decidia capsularis. And this one, which is covering the uterine cavity, this is Decidia. So number 1 is Decidia. So number 1 is Decidia. I'm assuming that probably our answers are not coming at same time. That's how I can think positive. So this is Decidia paritalis. So it is very simple. The Decidia which is present below the blastocyst is basalis, covering is capsularis, rest of uterine cavity is paritalis. Now please see the picture number 2. Please see the picture number 2. So in the second picture, if you're observing that the fetus or the blastocyst is not same, it is growing. So when it grows, do you see like here capsularis and paritalis? यहाँ पे जैसे capsularis and paritalis है. Do you see something same like that here? No. So like how we have capsularis and paritalis here, capsularis and paritalis here, here you don't see the same. So here the capsularis and paritalis are fused already. And when the capsularis and paritalis is fused, what do you call that layer as? Very good, Dev. Excellent. That is called Decidia vera. That is called Decidia vera. Very good. Very good. So that is the Decidia vera. Now, can you tell me what is number 6? The purple one. This purple finger-like projections. What is this layer called as? Excellent, Dharmesh. So this is called as chorion frondosum. And below the chorion frondosum will be the Decidia basalis. And the Decidia which is covering, this is Decidia vera. Below the Decidia vera, you have chorion levae. Chorion levae. Finger-like will be chorion frondosum. Not finger-like, just present below the Decidia vera is called as chorion levae. And this is the amniotic cavity. This is the amniotic cavity. So that finishes about the basics of reproduction, anatomy. So one last thing and then we'll go to the next topic. So intrauterine periods, the ovular or the germinal period is from the fertilization to 2 weeks. Embryonic period is 3 to 8 weeks. Fetal period is more than 8 weeks till delivery. Most important to us is embryonic period, that is 3 weeks to 8 weeks, because maximum teratogenesis takes place in this time. Why? Because organogenesis is taking place in this period. Because organogenesis is taking place in this period. So that finishes the topic number 1. So after every topic, I want you to leave one page. Conjuse ho to half page, not conjuse to full page. Why? While you're solving MCQs, if you if you feel some mistakes or if you have learned some new points in that, so that you can write it there itself. See, although this notes you are preparing for FMGE, 90%, 80% of the same will be there for your NEET also. So I have seen many students carrying forward this same notes for the NEET also. So try to give some space so that in future when you're preparing for NEET, so you can add off any other further points. So 1 to 2 pages thoda chhod ke you go forward. Okay. Right. So we'll go to the next topic, that is placenta. So the next topic is placenta. So we will discuss how does a normal placenta, how does it develop, what are its functions, and what is the abnormal placenta. So this is how the normal placenta looks like. So we describe the human placenta as discoid because the shape of the placenta is discoid. So you describe it as discoid, hemochoroidal. Hemochoroidal because it has both blood from both mother as well as baby. So hemochoroidal, 2 bloods. And it sheds off after delivery. So that is why you also call it as deciduate. Now who forms the placenta? I'll just go back to this picture again. So placenta is formed by chorion frondosum and decidua basalis. This entire portion is the placenta, guys. So chorion frondosum and decidua basalis together form the placenta. So placenta develops from decidua basalis plus chorion frondosum. So there are 2 surfaces of the placenta. This is the maternal surface and this is the fetal surface. If you observe, maternal surface is rough, shaggy, pink and divided into multiple lobes, and each lobe is called as cotyledon. So maternal surface is rough, shaggy, divided into multiple lobes. Each lobe is called as cotyledon. Each lobe is called as cotyledon. So cotyledon is the functioning unit of the placenta. Cotyledon is the functioning unit of placenta. So normally we will have around 15 to 20 cotyledons, guys. So this one, each one cube is cotyledon. So we have around 15 to 20 cotyledons in each placenta. Fetal surface will be smooth, glistening. Why? Because it is covered by amnion. Fetal surface will be smooth and glistening because it is covered by amnion. Can you see that white layer? So below the amnion is the chorion, and in the center of the fetal surface you'll have the umbilical cord, and you'll have umbilical cord in the center. And you'll have umbilical cord in the center. How does the placenta forms? First I'll make you write in brief, and then we will see one video which beautifully explains how does the placenta forms. So development of placenta. So first we have the primary villi. Basically, the fetus is trying to put finger-like projections into the decidia, so that it anchors into the maternal surface. So first primary villi is formed on day 12. So first layer which we have is the decidia basalis from the mother. Below the decidia basalis, you will have the syncytial trophoblast. So syncytial trophoblast will have lacunae formed. Inside the syncytial trophoblast, you will have the lacunae formed. After the layer of syncytial trophoblast, you have cytotrophoblast, which will make finger-like projections. You will have cytotrophoblast, which will make finger-like projections. So around day 15, the spiral arteries enter into this intervillar space to release maternal blood. So around day 15, spiral arteries will enter into the intervillar space to release maternal blood into the intervillar space. So day 15, so that I will call it as uteroplacental circulation is established. So primary villi day 12. So decidia basalis, syncytial trophoblast, cytotrophoblast. Syncytial mein you have the maternal spiral arteries entering, and that is called as uteroplacental circulation established. I want you to draw 3 diagrams, but I will draw only one diagram. मैं एक ही diagram में I'll add on, but you draw 3 separate diagrams. ठीक है? So next we have secondary villi. In New Williams, they didn't mention when is the secondary villi formed, guys. So I follow the New Williams, so I am going to speak as per the Williams itself. So only thing which is extra in the secondary villi is, in secondary villi, below the cytotrophoblast, you will have one more layer that is called as extra embryonic mesoderm. I will show you the video which will explain you everything, but I'll show it post break, not now. So you have the extra embryonic mesoderm, but that is only thing which is extra in the secondary villi. That is the only thing which is extra in the secondary villi. Next comes the tertiary villi. So earlier books we used to give that tertiary villi is formed on day 21. But recent Williams tells that tertiary villi is formed on day 17. So let us stick to the recent guidelines. Tertiary villi is on day 17. The only thing which is extra in the tertiary villi is fetal capillaries enter into the villi. So the tertiary villi में fetal capillaries are entering into the villi. So this is the fetal capillaries. So fetal capillaries enter into the tertiary villi. Now you tell me, based on this image, do you have mixing of blood between the maternal and fetal? So maternal blood is in the intervillar space, whereas fetal blood is in the inside the villi. Fetal blood is inside the villi, whereas maternal blood is inside the villus, in the intervillar space. So you don't have mixing of blood, and these layers which are present between the maternal blood and fetal blood, these layers are called as placental barrier or placental membrane. So can you tell me what are all layers which are constituting the placental barrier? So can you tell me what are all the layers which constitute the placental barrier? Yes, Shweta, excellent. So can you tell me what layers are forming the placental barrier? I want you to people to attempt what all layers. Cytotrophoblast and syncytiotrophoblast, all these are the layers, and this entire part, this entire thing which is forming the finger-like projection, this full thing which is forming the finger-like projection is called as chorion frondosum. So Raima, chorion frondosum is nothing but the cyto and syncytio. Cyto syncytio together we are calling it as chorion frondosum. Okay. Secondary villi forms on which day is not been given in the Williams, so I am also not mentioning. Excellent, Raima. So you have answered it correct. So placental barrier is formed by outermost layer is the syncytiotrophoblast. Inner to syncytio you have the cytotrophoblast. Inner to cyto you have the blue color one, that is extraembryonic mesoderm. Inner to extraembryonic mesoderm is the fetal capillary endothelium. So these form the placental barrier. Very good, Shweta, excellent. So I will try to play the video now if I can. Otherwise, I'll play after the break. Okay? Just give me 1 minute. So you keep answering when is the primary villi formed and when is the secondary villi formed.
Development of the placenta begins during implantation. When the blastocyst adheres to the endometrial epithelium.
So if you observe, this is the blastocyst. So in the blastocyst, you have the outer syncytial and inner cytotrophoblast. Outer syncytial and inner cytotrophoblast. So cytotrophoblast will be releasing the proteolytic enzymes to form the lacunae inside the syncytiotrophoblast. So this is the blastocyst. So can you see inside the lacunae? Fetal, maternal blood or the blood from the spiral arteries are going. So these are the lacunae which are getting formed in the syncytiotrophoblast. So Decidia basalis, syncytio, cyto and so cytotrophoblasts forming finger-like projections into syncytiotrophoblast. This becomes which villi? This is the primary villi. Next, extraembryonic mesoderm is also forming finger-like projection. So this becomes which villi? This is the secondary villi. Next, fetal capillaries also will form the finger-like projections. So this becomes which villi? This becomes the tertiary villi. So the entire cytotrophoblast will form a shell called cytotrophoblastic shell. So these are the villi. This is the actual view how it is happening inside the placenta. So those villi may you're having that extraembryonic mesoderm, fetal capillaries and all. And the space in between the villus is the intervillar space. Space in between the villus is the intervillar space. And through the intervillar space you're having the maternal blood running. The blood from the spiral arteries. And through the villus you are also having between the villus it is the maternal blood, through the villus it is the umbilical arteries. Yes. So inside the villus you are having the fetal blood and in the intervillar space you are having the maternal blood. And placental barrier you already know. So all these lacunae are present in the syncytiotrophoblast. All these lacunae are present in the syncytio. Beautiful. I hope you all understood now how the placenta is formed. So umbilical vein always brings the oxygenated blood. So that is the blood coming out from the spiral arteries. These are the maternal surface. So all that is the cotyledon. So all that is the cotyledon. This is the fetal surface which is smooth and glistening. In the center you are having the umbilical cord. Understood all of you? So it's a beautiful video which explains everything. I personally like this video a lot. Right. Now let's go to the next thing, that is you should know here some single liners. I think it is. Okay. So now next important points which you should be knowing is uteroplacental flow rate and placental flow rate. Those all some simple points, but yet you have to know them. So this is the 3D picture of the tertiary villi. This is the 3D picture of the tertiary villi, guys. So I want you to answer these layers now. So what is the A here? So this side where the spiral arteries are coming is the maternal side. So this one is the deciduum basalis. So where you are seeing the intervillar space and blood from the spiral arteries. So this is the blood from the spiral arteries, or the it is the intervillar space. Covering the intervillar space, this small dot dot green color one, that is the syncytial trophoblast. Syncytial trophoblast. Inner to syncytial trophoblast. Inner to syncytial trophoblast, which is showing some cells like. So the B is nothing but the cytotrophoblast. Inner to cytotrophoblast, where I have written A, that is the extraembryonic mesoderm. So this is a tertiary villus. This is a tertiary villus. So what I have showed, what I have drawn was basalis up and other layers down. But what I am asking is fetal surface up and basalis down. So first the uppermost which you are seeing is the extraembryonic mesoderm. Then you have the cytotrophoblast. Then you have the syncytial trophoblast. Then outermost is the deciduum basalis. Okay. Now this is a very, very important slide. I want you to remember this because I've seen some MCQs. So the villi will carry fetal blood volume of 350 ml. Intervillar space, which has maternal blood, will have the volume is 150 ml. Uteroplacental blood flow at term is 450 to 650 ml per minute. And uterine blood flow rate. Uteroplacental blood flow rate is 450 to 650 ml per minute. But uterine blood flow is 800 to 900 ml per minute. Fetal blood flow through the placenta is 400 ml per minute. So that's about the normal placenta. That's about the normal placenta. So at Okay, I hope this is fine. And regarding the normal placenta, so on the whole, placenta is formed from chorion frondosome, means all these will trophoblasts, syncytial, cyto, all that together I'm calling it as chorion frondosome, right? So placenta at term will be 500 grams. Fetal weight to placental weight will be 6:1. So if baby is 3 kgs, placenta will be 500 grams. If baby is 3 kgs, placenta will be 500 grams. So I hope you have written this. And I just want you to write this one last sentence. At term, 4/5 of the placenta is of fetal origin. So only 1/5 is from the deciduobasalis. 4/5 is all the cytotrophoblasts, syncytia and all, no? So at term, 4/5 of the placenta is of fetal origin. At term, 4/5 of the placenta is of fetal origin. So what are the functions of the placenta? So now we'll write down the functions of the placenta. Can you tell me certain functions of the placenta? So one, it is having the barrier function. Next, placenta is the one which gives the nutrition to the baby, takes out the excretory products as well as gives the oxygen. So it acts as a nutritive role. It has respiratory role. As well, it also has excretory role. So this placenta itself is the nutrition, respiration, excretion, everything. So it has a lot of endocrine function. It secretes a lot of hormones. So it has endocrinal function. It also produces enzymes. And it also has immunological role. See, what do I mean by immunological role is, why don't we reject the fetus? All the fetus contains paternal antigens which are foreign antigens. So we don't reject the fetus although it contains the foreign antigens, because there is no HLA expression on the villi. So the trophoblast which I've taught, syncytio and cytos, this on syncytio and cyto you don't have any HLA expression. So as there is no HLA expression, it is not recognized as a foreign antibody. Okay. So now we'll discuss in detail about the endocrinal function, guys. Again, in endocrines, it produces many hormones, but I would like to speak specifically about few hormones because we have MCQs on few hormones. So I want you people to write down what are all the hormones which are produced from the placenta. Yes, so it produces the HCG, beta HCG, human placental lactogen. human placental lactogen. So human placental lactogen this human placental lactogen is an anti-insulin hormone. It is anti-insulin. It is produced from 28 weeks, from 24 to 28 weeks, and maximum at third trimester. So maximum production of this occurs at third trimester. And the function of this is, as I told you, it is anti-insulin. So it causes lipolysis, so that there will be continuous increased glucose levels, so that continuous glucose will go to the baby. So it causes lipolysis. So human placental lactogen is an anti-insulin hormone which causes lipolysis. It's produced from 24 to 28 weeks and it is maximum at third trimester. I want you to remember this hormone. I'll ask you in the GDM, gestational diabetes mellitus. Now progesterone is like a hero hormone in the pregnancy. Why? Because it relaxes all the smooth muscles. So it causes uterine relaxation, preventing the abortion. It produces area stellar reaction. That is what it is, the one which is causing the decidualization. So it forms a soft cushiony decidua. This progesterone is produced from maternal LDL cholesterol. Progesterone is produced from or formed from maternal LDL cholesterol. So estrogen, placenta specifically produces, there are 3 types of estrogen, guys. Actually now, according to the recent guidelines, how many types of estrogen are there? Any idea? So according to the recent guidelines, we have 4 types of estrogen. So the estrogen is synthesized from fetal dihydroepiandrosterone sulfate. Now before you write this, what are the 4 types of estrogen which we have? So we have 4 types of estrogen. Earlier it was 3 types. Now it is 4 types. So we have estrone, E1. So when will be women all alone? Menopause. So estrone or E1 is in the menopause. Estradiol, E2 is seen in reproductive age group. Estriol, E3 is seen in pregnancy. So estradiol, husband-wife, reproductive, husband-wife, bacha, estriol, pregnancy. The 4th estrogen is estetrol. 4th estrogen which has been identified is estetrol. Estetrol. This is also specific to pregnancy itself. So in pregnancy, most common estrogen is estradiol. But specific to pregnancy is estriol and estetrol. Estradiol will help in the growth of the uterus. And because of the estrogen, we have the melasma and hyperpigmentation because it stimulates the cortisol. Estradiol increases the thyroid binding globulin. Estradiol retains the salt and water and it causes the gallbladder stasis. Among these 4 estrogens, which is the most potent estrogen? E2 is most potent, followed by E1, followed by E3. Regarding E4, it is just identified, so potency and all has to be told. Okay. Next. So I hope you have all written this. Next, coming to the HCG. So HCG is human chorionic gonadotrophin. It's a glycoprotein. It's a glycoprotein. So you have 2 subunits of HCG. So you have alpha subunit and you have beta subunit. Alpha subunit is non-specific and it is similar to LH, FSH and TSH. But beta subunit is specific. Alpha subunit is non-specific and it is similar to FSH, LH and TSH. But beta subunit is specific. So HCG doubles every 48 hours. What is the function? What is the use of HCG to us? Matlab, you would have already know one use of HCG. I want you people to write in the comment box ki what is the use of HCG. Where do we use HCG in our day-to-day practice mein? So HCG doubles every 48 hours. Maximum HCG levels is present around 10 weeks. So I am assuming you have written this point. So maximum HCG is at around 10 weeks. So at 10 weeks, you have the beta HCG rises, it is maximum and is around 1 lakh international units per liter. So it is around 1 lakh. Then it comes down or drops down by up to 16 weeks and then it remains like a plateau. So maximum is at 10 weeks. Best test to detect HCG is excellent, Nilesh. Correct. So UPT, urine pregnancy test. UPT, that is urine pregnancy test. The card which we use helps us to tell whether she's pregnant or not by measuring the beta HCG levels itself. So to confirm the pregnancy, we use the beta HCG levels, right? So best test to detect beta HCG is fluoroimmunoassay, followed by radioimmunoassay, followed by immunoradiometric assay, so the best test to detect is fluoroimmunoassay followed by radioimmunoassay and immunoradiometric assay. So UPT is an agglutination card. So for UPT to be positive, beta HCG level should be more than 25 international units. So for UPT is a card agglutination. So when beta HCG is more than 25 international units, UPT will be positive. Next, very important is what are the conditions where beta HCG will be high and what are the conditions where beta HCG will be low. That is important. This has been asked as an MCQ, guys. So what are the conditions beta HCG is high and what are the conditions beta HCG low has been asked as an MCQ. So that you should be knowing. So increased levels of beta HCG, you can remember with the mnemonic of mentally retarded pediatrician, MRDCH. So M, multiple pregnancy mein beta HCG will be very high. R, RH isoimmunization mein it will be high. D, Downs mein it is high. C, choriocarcinoma. H, hydrated mole. In all these conditions, beta HCG is high. So the level of beta HCG in Downs has been asked as an MCQ. So Downs may beta HCG will be high. So what are the conditions where beta HCG will be low? So beta HCG is low in ectopic pregnancy, abortions, and in Edwards syndrome. So Edward is what? Trisomy. Edward is trisomy. So Edward is trisomy. Trisomy 18. Edward is trisomy 18. Whereas Downs is trisomy 21. Downs is trisomy 21. Right? Okay, now functions of HCG are it maintains the corpus luteum. It maintains the corpus luteum. It helps in the growth and development of the umbilical cord. It is the first stimulus for the release of testosterone from the male fetus. And it also helps in immunosuppression. So these are the functions of beta HCG. So that is regarding the functions of placenta. So we have discussed about the normal placenta. So how is the shape? How is it formed? What are the functions of it? What are the hormones it releases? And regarding the hormones, now we'll take a small break of 15 minutes and we'll come back and we'll start discussing about the abnormal placenta or variations of placenta. So I hope you're all able to understand the session and you're able to jot down everything. Any doubts or anything, feel free to ask before we go for another break. So you are all able to understand Chirag, Nilesh, Arjun, Shweta, Raima, Karthik. So any doubts still here? Now most important thing guys, whatever I complete today in this session, I want you to revise it before you come to the next session tomorrow morning. Okay? So आज whatever we will finish, no, those topics before you sleep, you should revise everything. So 80, you should like one revision should over along with me, like that. So these 5 days I want you to be giving you 100% dedication. You should be completely dedicated, okay, so that you will digest the obstetrics and gynecology perfectly. Okay, so very good, excellent. I'm happy that you're all able to understand, it's clear. So I will see you all within 15 minutes. Thank you guys. Take a small break, have something, tea or anything, and come back. हाँ ब्रेक है, मैंने बोल दिया ब्रेक करके.